All right, perfect. So good morning, everyone. Can you hear me okay? All right, perfect. For those of you who don't know me, my name is Tashina McCluskey, and I'm one of the clinical nurse educators at the St. John Regional Hospital ICU. Thank you very much for having me today. Today, I will be talking to you about post-intensive care syndrome. Things like, what is post-intensive care syndrome? Who gets it? What are the risk factors, and what can we do about it? So first up, what is post-intensive care syndrome? So over the last few decades, with improvements in healthcare technology, survival of ICU patients has dramatically increased despite advancing age and severity of illness in our own population. I've seen it in my own career. 20 years ago, when I first started nursing, if anyone over 75 was admitted to the ICU, we were like, why? Why are we doing this? But now it's not unusual at all for people in their 80s and above to be treated for their critical illness and discharged out of the ICU back either to their homes or to long-term care facilities, basically back at a normal level of functioning. Also back then at the beginning of my career, if someone had told me that a patient sick enough to be on ECMO after describing to me what ECMO was, would not only get out of ICU, but be well enough to return to drop off chocolates to our charge nurse a few months later, my mind would have been blown. So people sicker, advancing age, actually getting better in the ICU. I digress. As I said, with more people surviving ICU stays, attention has begun to shift to long-term outcomes for these patients. It's being acknowledged now that surviving ICU doesn't necessarily mean a complete recovery, even if they are dropping off chocolates to the nurses. So back on September 27th and 28th of 2010, the Society of Critical Care Medicine held a conference to try and better understand the long-term outcomes of intensive care patients, their families, to identify gaps in the literature regarding these outcomes, and to identify strategies to improve these outcomes. Findings on the conference were later published in Needham et al. In 2012. That's this reference down here. They coined the term at this time post-intensive care syndrome, or PICS or PICS, which they described, as the slide says, as a new or worsening impairment in physical, cognitive, or mental health status arising after critical illness and persisting beyond the acute care hospitalization. These new impairments can't be explained by other causes, such as traumatic brain injuries, cerebral vascular accidents, physical injuries, etc. It's important to note that PICS is not a medical diagnosis, but more of a concept to help improve both the education and awareness of these symptoms in these patients and their families may face. So Needham et al. Use the examples of both stroke rehabilitation and oncology care as two areas which used to focus primarily on short-term treatments of patients, but have since expanded to focus on the long-term outcomes and how to maximize their patient status once the initial progress of care has completed. They hoped by giving it a name, PICS, as an umbrella term to describe all these things people are going through, it would make it easier for the research to focus more on these things. And it has. There has been a slow increase in awareness over the last decade, but it truly has exploded in the last few years with the COVID pandemic. Large numbers of ICU patients, many of which were potentially healthy prior to admission, the strain of the healthcare system overall, as well as the isolation that was felt by these patients and their families, are just a few of the things that have led people to start to consider what happens next after ICU. Oops, sorry, I went one slide too far. Okay, so let's expand a little bit on these three domains of PICS. Obviously, there can be a lot of overlap between these categories, and patients can experience impairments in one, two, or all three. And they can last for a long time. Rates in the literature vary because of lack of consensus about assessment methods, populations, etc. But one study found about 64% of survivors had at least one impairment at the 3 months post-discharge, and 56% still had some sort of impairment in one of these three domains or more at 12 months. So, first domain here is physical impairments. Between 25 to 80% of adult ICU survivors have some sort of prolonged physical impairment. Out of these three domains, physical problems seem to be the most prominent. Weakness and fatigue, those are the two big ones. ICU acquired muscle weakness, with subdivisions being things like muscle deconditioning, critical illness polyneuropathy, critical illness myopathy, are present in about half of the patients who survive ICU. Fatigue, on the other hand, is reported in upwards of 70% of patients at the 6-month post-discharge mark and 60% at 12 months. Dyspnea can also occur due to muscle wasting of the respiratory muscles, due to either mechanical ventilation, medications such as opiates, sedatives, or neuromuscular blocking agents. And as you can imagine, because of the weakness, the fatigue, and the dyspnea, many of these patients have impaired mobility. One study found approximately a quarter of ICU patients still required assistance with their ADLs, their activities of daily living, a year after discharge. Pain can be present in patients, up to 50% of them at the 12-month mark. And another study found that between around 35% of medical and surgical ICU patients continue to report pain at their follow-up visits, compared to a rate of about 20% chronic pain rate in the general population. And then finally, sleep disturbances can also occur, either due to the dyspnea, the pain, the mental health problems, which we will talk about later on, which only increases the fatigue and the weakness that these patients send. So, potential factors that can contribute to the respiratory and muscle weakness include the prolonged bed rest that many ICU patients face, increased catabolic state, basically decreased nutritional status, means that their muscles get eaten up, and also ischemia of the microvasculature of the muscle and nerves. The next domain we're going to talk about is the cognitive impairments. So approximately 80% of ICU survivors have some sort of prolonged cognitive dysfunction. Usually this does improve over time, but sometimes it can persist for years, especially in patients that had sepsis or ARDS, acute respiratory distress syndrome, for an admitting diagnosis. These impairments can present as things like memory loss, problems with attention, decreased executive functions like organization and problem solving. One testimonial I watched on YouTube had a former grocery store manager, and he was used to the mental tasks of tracking inventory, managing vendors, payroll for his employees, and things like that. And he was talking about how after his ICU stay, he actually needed his wife's help to help fill out his child's school application. He said it was incredibly frustrating because this is something that would have taken him maybe a minute or two pre-ICU. And now it literally took him hours before he eventually asked for help. He just did not have the mental cognitive ability to focus and fill out these forms. If someone already has an underlying cognitive dysfunction, like mild Alzheimer's, then ICU stays can absolutely increase and cause some significant further decline as well. And then finally, the third domain is mental health or psychological health. The ICU experience can be frightening and isolating and dehumanizing to many, many people. And these patients often have a lot of pain, confusion, and disorientation, either related to their treatment or just because of whatever brings them into ICU. This can lead to depression, anxiety, or even PTSD in patients with no previous mental health history. Medical anxiety seemed to be particularly prevalent in the testimonials I watched. People had stories like they would come down with a cold and it would just bring that whole ICU experience back, and the anxiety that they might have to go through it again could have been completely overwhelming. Also, when compared to patients requiring hospitalization but not ICU admission, so just general hospitalization, ICU survivors have an increased risk of both self-harm and suicide, most likely related to PTSD, anxiety, and depression. Again, these domains can overlap. Cognitive impairments can exacerbate depression. Depression can increase fatigue. Nightmares can cause sleep disturbances, which cause weakness and attention problems, and so on and so forth. Another important factor that isn't mentioned here is that there's financial and social issues that many of these patients face. Think back to the grocery store manager I mentioned previously. He lost his job because he was no longer able to perform the duties required of him. And his case isn't unusual. Less than one half of patients who were employed prior to ICU admission are still employed at the 1 year mark post discharge. And about a third remain jobless after 5 years. There's also additional financial issues due to medical bills, potentially loss of savings, loss of home, and these people are also at increased risk of rehospitalization and mortality compared to other patients. Just, excuse me, as a little side note, there is also what is known as a post-hospital syndrome, which involves several functional impairments that occur, especially in older patients after prolonged hospitalization for non-critical illnesses. However, post-intensive care syndrome is distinct from this, not only because it can affect all ages, but also that the impairments related to post-hospital syndrome tend to be very transient from days to weeks, whereas PIC symptoms tend to be enduring, like I said, sometimes for years in these patients. All right, so these are results from a study in the Netherlands cited by Heiser et al. 2023, which looked at 2,345 ICU survivors. I really like these results for two reasons. First off is because they split things up by reason for admission. It's easy to think like, oh, of course this massive trauma or this super septic patient is going to have ongoing weakness, cognitive issues, things like that. But even those who land in ICU post-elective surgery can develop PICs. I think of our non-emergent cardiac surgery patients or our VATS/RATS patients, so video-assisted or robotic-assisted thoracic surgeries. Even if they are being fixed and things go according to plan, they may still end up with the long-term complications that will affect their quality of life. Less risk than the urgent emergent surgeries or the critically ill medical admissions, but the risk is still there. Second reason I like this study is because they actually did use validated scales to look at these specific impairments based on scores pre-ICU, which were obtained prior to surgery in the cases of the elective surgeries and retrospectively for the emergency and medical cases. So fatigue was measured using an 8-item subscale of the 20-item checklist for individual strength, or the CIS-20. And at the 1 year mark, 45% of urgent surgery patients, 36% of medical patients, and 24% of elective surgery patients did have some increased fatigue prior to their ICU. Depression and anxiety symptoms were measured using the Hospital Anxiety and Depression Scale, or the HADS. And again, urgent and medical are high, but elective surgery still had them there too. Frailty was measured using the Clinical Frailty Index, and PTSD symptoms were measured using the Impact of Event Scale revised, or the IES-R. This particular study also looked at physical impairments, but they didn't use validated questionnaires, so Heiser et al. Didn't include it. But overall, the PIC symptoms from at least one of the three domains were present in about 64% of patients for urgent surgery, 58% for medical admissions and 43% for elective surgeries. So quite significant numbers. So why do some people get PICS and some people don't? For the non-modifiable risk factors, advanced age equals advanced risk makes sense. Greater than 60 seems to be the common number in the literature. Female sex is also associated with high risk, especially for mental health impairments. Baseline frailty, if you're more frail going into ICU, you're at higher risk for being even more frail coming out. Similarly, if you have some sort of physical disability, cognitive impairment, or mental health disorder, you have an increased risk of a worsening one after leaving the ICU. Patients with an admitting diagnosis of acute respiratory distress syndrome, ARDS, or sepsis are also at increased risk, possibly due to the increased length of stay, increased level of illness, inflammatory mediators, things like that. So potentially modifiable. So mechanical ventilation. If you need to be mechanically ventilated and the longer you remain mechanically ventilated, you do have an increased risk of PICS. Diaphragm musculature thinning has been seen on CT in as little as 2 days of mechanical ventilation. So very, very quick decline there. The longer your length of stay, the increased risk of PICS, which makes sense. Finally, any sort of complications of your ICU stay, such as decompensation into shock states, multi-organ failure, or even transient periods of hypoxia can increase your risk of PICS. Now for the most important one, the modifiable risk factors. So sedation use. This includes time on sedation and dosage, longer equals worse, and type of sedation. Benzodiazepines are the worst choice, which I think most people know at this point. Proper pain management is also important. We'll talk about that a little later on. Delirium. So while not always completely avoidable, delirium can be screened for, managed, and minimized. Immobility, even small range of motion exercises can decrease the risk of PICS. Unless your patient is completely hemodynamically unstable, then they should be up and moving at least a little bit several times a day. Sleep disturbances. So it's very, very difficult to get a decent sleep-wake cycle going on for ICU patients with all the lights and the noise and the procedures and everything else that happen. But it should be a goal that people work towards to try to avoid sleep disturbances in these patients. Hyperglycemia. So hypoglycemia is also increases the risk of PICS, but it tends to be more quickly managed than the hyperglycemia. So that's why they kind of focus on that one here. Main thing is check your patient's sugars and make sure that they're well managed. And then finally, negative memories of the ICU. I'd argue that this one is also only potentially modifiable rather than completely modifiable, but there are ways to improve this factor. Speaking directly to the patient, even if you think they're fully sedated, avoid overly medical terminology when speaking in the room, explaining procedures before doing them. Again, even if you think if the patient is fully sedated. This was one thing that came up again and again in the testimonials. People having experiences where they are laying in bed and they're full of tubes and they're unable to move, aren't able to speak, and there's strangers around them all talking in a language that they may or may not understand. And all they hear about is how sick they are and how they're probably going to die. As you can imagine, there's no wonder why these people would potentially end up with PTSD. So I'm not going to spend a whole lot of time on this, but I did want to mention that many of these symptoms, mostly the mental health ones, can affect family members as well. Anxiety, depression, PTSD, complicated grief, caregiver burnout, things like that. I'm getting low on time, so I'm going to start speeding up a bit. So this is a paraphrase of an actual quote I got when I shared an article about PICS with our ICU staff. I was basically met with, "This is kind of depressing to think about, Tashina." Good news is, not knowing about something doesn't mean it doesn't exist, but once we do know about something, we can do something about it. And one of the major things that can be done for these patients is to evaluate them for PICS early and start managing those symptoms. Current recommendations state that all ICU patients should be assessed for PICS, preferably in a primary care environment where people know their past medical history and everything like that, and preferably within 2 to 4 weeks of hospital discharge, although an evaluation prior to hospital discharge wouldn't be unreasonable either. The index of suspicion needs to be high with these people. Dedicated PICS clinics are becoming more prevalent. However, many of the assessments can be modified and completed in a post-op, post-procedure sort of evaluation setting as well. At the very bare minimum, all post-ICU patients should have a chance to review their course in ICU, both to assess how their experience was, fill in any gaps in their memory, and answer any questions they may have. They should also be assessed for any lingering symptoms. A med rec should be completed to make sure their medications are optimized, as well as a basic health screening to rule out any potential differential diagnosis, such as strokes, spinal issues, ongoing electrolyte or nutritional disorders, new dementia, Alzheimer's, things like that. Any reversible causes of PICS should be managed. Any new symptoms, new conditions found should be managed. And again, the index for referrals should be very low. Things like physiotherapy, occupational therapy, things like that. Next up is just kind of a little bit more of how you can assess these different cognitive things. I split up physical and respiratory just because they're a little bit different, but a couple of different things. Cognitive, such as the MoCA, MMSE, Barthel Index to assess activities of daily living. Mental health, the HADS, the IESR, we've talked about that a little bit. And then again, management. So referrals to physiotherapy, referrals to occupational therapy, referrals to pulmonary rehab to try to get those respiratory muscles back up. Social work, counseling, psychiatry, things like this. Just really utilizing that interdisciplinary team. The sooner we can find these symptoms and these patients and start working towards treating them, the quicker we can improve their quality of life. But of course, the best treatment for PICS is prevention. So going back to those potentially modifiable and modifiable risk factors. So if you work with patients in a critical care environment, this is either ICU, CCU, whether you are a physician, a registered nurse, a nurse associate, a pharmacist, a respiratory therapist, any other member of the interdisciplinary teams, there are things that can be done to reduce the risk of PICS in these patients. Again, pain and management sedation, treating the pain, minimizing sedation, things like that. Spontaneous breathing trials, so seeing if the patient is actually able to tolerate spontaneous breathing and hopefully get them off mechanical ventilation quicker. Daily sedation vacations or sedation interruptions are also associated with lower levels of PTSD in these patients. Delirium management is a whole topic on its own, but basically things like frequent reorientation, getting rooms with windows, reducing restraint use are all things to help reduce potential delirium. Early mobilization, talked about this, even if it's just some range of motion. Obviously getting up to a chair or getting out of bed is better, but in the super sick people, even just range of motion is good. Nutritional assessments, increased family engagement, so frequent family meetings, involving them in patient care, increased communication, talking about speaking directly to the patient, decreased use of medical jargon, the use of ICU diaries, where basically nurses and family members can write down the patient's ICU course so they can review it later on to kind of fill in any gaps of these memories. And another important thing to do is to educate the patients and families about PICS. And yes, let them know that just because they survive an ICU stay doesn't mean they won't potentially have long-term effects. Going back to those testimonials, one of the most frequent comments I saw in the comment section of the YouTube videos was like, I thought that this was just me. It makes me feel so much better to know that I'm not alone at this and that this is unfortunately something that happens to people after a critical illness or injury. Just having that knowledge that it's not just them helps people move on past at least some of these psychological symptoms. So where do we go from here? More research, putting more standardized approaches into it, more education, things like this, just bringing out that these things happen both to healthcare professionals so they know what to look for, and family and patients. And then multidisciplinary treatment strategies. Like I said, early physiotherapy, early occupational therapy. things like that. Sorry, I kind of went fast and furious there at the end just for time, but that is it for me. Thank you for listening. If there's any questions or comments, I can do my best to address them in the next couple of minutes. And there's my references there as well.
Tashina, thank you so much. I think it was an excellent presentation on this very important topic. Are there any questions from the audience? Okay, I will probably ask a question. So from your research and from your experience, what do you think is the biggest driving factor? Is it a truly multifactorial process, or you can isolate one factor which we can prioritize and start addressing first, and then everything else? What's your opinion?
So most of the literature did say that one, physical impairments seem to be the largest one, and they also seem to influence both the cognitive and the psychological factors the most. Plus, they were most amendable to actual therapy. So if we were going to pick one thing, I would think things like early mobilization, early ventilatory weaning, just focusing on those physical impairments, and then hopefully the rest of them will help along the way, kind of thing.
Thank you. Thank you so much. So there is a question from the
Oh, yes. So what is being done to prevent, screen, follow? That is a great question. Where I focus mostly on ICU, with our prevention strategies, we do definitely do spontaneous breathing trials at least once a day on all of our appropriate patients. We absolutely try to do the early mobilization, like I said, as long as they're neurologically and hemodynamically stable enough for that. We screen for delirium using the KMICU at least once a day, and then try to initiate delirium prevention. But there's still so much more to do. It's certainly one of those topics that is becoming more popular. At a recent critical care conference I went to, a lot of focus was on this. Like I said, since post-COVID, a lot more people are starting to realize like, oh, this really is a thing and it's stuff that we should do with. So I hope that certainly more and more will be done the more it gets out there.
I see. Thank you so much. So what? It's a long-standing process.
Yes.
And what do you think will be our deliverables if we decide to address it? So you perfectly isolated what we can do, but we need to measure our deliverables, our outcomes. So how would you approach this?
That's a great question. Certainly, as I mentioned, these patients do have a tendency to be rehospitalized due to either physical impairments, respiratory impairments, and things like that. So certainly, rehospitalization rate is something that we could look into. Quality of life is the big one, especially from a nursing standpoint. We want these people to go back out into society and preferably return to be productive members of society as well. That one is a little bit more difficult to measure, and there's a lot more factors to it, especially from a hospital setting. But I think definitely, if I can go backwards on my slides here.
Yes, please.
Just measuring some of these assessment tools, and just kind of like focusing on, okay, 2 to 4 weeks post ICU, these are your scoring levels. When we have, say, like a 6-month follow-up or something like that, we do them again, and just to see the improvements that way, preferably, again, with management strategies. Hopefully, like I said, that will lead to some improvements with these patients.
Great, thank you so much. Any other questions? Okay.
Yeah, I do. I do,
Please.
Ivan. I don't know if you can hear me.
Yes, we can perfectly hear you.
Yeah. Thank you, Tashina. That was really, really, really good. I wonder if you were able to discern it. You know, in my mind, there are clearly ICU patients, but we also have in cardiac surgery, for example, a large proportion of our patients that are simply recovered in ICU. They only, a few hours. Do these patients, are they a little bit different? Are we thinking of them different? They're obviously at risk, but if their transition into the ICU and the care and the ventilation is only a few hours, are they that same group of patients also?
Honestly, and that is such a great question, because that is something that I tried to dig into, like, what is the hour mark? Because you were certainly right, like most of our post-cardiac surgery patients are only in ICU for less than 24 hours. And we try to get them extubated within 2 hours. Therefore, are they at the same amount of risk as these general people? My personal opinion would be no. Again, because length of ICU stay is lower, length of time on mechanical ventilation is lower, length of time on sedation, things like that are lower. However, I couldn't find anything concrete that said that these patients are or are not at higher or lower risk.
Yes.
My gut is definitely no, they are not, because their risk factors are so much lower. But then again, the concern with these patients is sometimes, as we all know, it takes longer to get some of these patients extubated based on comorbidities and things like that. These people might stay longer in ICU, and that certainly does increase the risk.
Yeah, I think it also highlights for us, why we are so trying to be so careful in assessing patients, frailty, mobility, cognition, all those things before, because the reality is, as you pointed out, all those risk factors just are become additive.
Exactly.
And, the worst thing in the world is you end up basically making patients, permanently institutionalized and or worse disabled than they were prior to their intervention.
Exactly. And this is where, especially for if you have time prior to surgery, a lot of those like pre-surgical ERAS recommendations, like building up their physical strength, building up their nutritional status, would definitely help, because coming out the other end, they'll be even stronger for it.
Yes.
Okay, excellent comment. Thank you, Jeff.
Yes, thank you.
Any other questions? Good. Thank you so much. Thank you for joining us, and thank you for great presentation. And I will see everyone next week. Have a nice day. Thank you.
Thank you.